Thank you for visiting this video segment of Dr. AFib. I'm Dr. Morales. Today we're going to be talking about beta blockers and why you were very likely prescribed a beta blocker. If you've been diagnosed with atrial fibrillation, it's very likely that at some point you were prescribed a beta blocker, which the most commonly used is metoprolol. However, there are a variety of others, including carvedilol, atenolol, labetalol, bisoprolol, just to name a few. So, why were you likely prescribed a beta blocker? Well, first, let's talk about the physiologic effects of these beta blocker medications. One, it works on the beta receptors throughout your body, and it can, one, lower your blood pressure, and two, slow down your heart rate. And what I tell my patients is that it basically has an anti-adrenaline effect. It actually blocks some of the stress-related hormones, particularly epinephrine and norepinephrine, and that's how it lowers your blood pressure and slows your heart rate down. But as far as atrial fibrillation goes, it has a few additional effects on it. One, it can reduce the frequency of extra beats of your heart, something called premature atrial contractions, which can help trigger episodes of atrial fibrillation. So it reduces the frequency of you potentially getting an episode of atrial fibrillation. In addition, if you're on a beta blocker medication and you're somebody whose AFib comes and goes, when you get an episode of atrial fibrillation, the heart rate will be less rapid because of the beta blocker medication. So those are some of the physiological effects of the actual medication itself. Another reason why people commonly get prescribed beta blockers, especially when they're first diagnosed with atrial fibrillation, is just familiarity. Beta blockers are used commonly in a lot of different other health conditions, including high blood pressure. It's also used for coronary artery disease, congestive heart failure. So a lot of doctors are very familiar with these medications. They're familiar with the dosages. In addition, beta blockers are very unlikely to have long-term side effects or cause long-term damage to any of your organs in your body, like your liver or your kidneys. So they tend to be safe long-term medications to use. And those are the variety of reasons why people end up being started on beta blockers. However, that doesn't mean that everybody can tolerate them. There are a variety of reasons why somebody would not be able to tolerate a beta blocker medication. One would be that your heart rate is just too slow. People who have AFib episodes that come and go, when you're not in atrial fibrillation, your heart rate may be very slow. It may be in the 50s or 60s to begin with. And so you would not be able to tolerate the addition of a medication like a beta blocker, which would slow your heart rate down further. Also, as I mentioned, the beta blocker medications also affect blood pressure. They have blood pressure effects. And again, there are some people who just don't have blood pressure, or don't have high blood pressure, should I say, and really can't tolerate the effects of the medication, and even low dosages of the beta blockers end up reducing their blood pressure too much. In addition, there are plenty of patients out there who don't really tolerate this anti-adrenaline effect that these medications can have. They just feel constantly fatigued or sleepy or dizzy or lightheaded from the medications. I've even had people describe to me that they just kind of feel like their head is in a fog a lot, or they're just walking through water, just kind of slowness of everything around them from the effects of the medications. And so even though these are good long-term medications to use, there are some people who just cannot tolerate it. Now, some of these kind of anti-adrenaline effects, this kind of foggy feeling, people can kind of get used to them and can continue taking them, but not everybody does. So in general, these medications are good long-term medications, but not everybody can tolerate them. And so if you're taking a beta blocker and you really feel that it's causing you side effects like fatigue or dizziness, please discuss these with your doctor, because there are actually many options available other than just beta blockers. Thank you for visiting this video segment of Dr. AFib. I'll see you next time.
Hi, this is Jim Christensen, and this is my presentation on calcium channel blockers. Calcium channel blockers are a type of medication that can be used by practitioners in the emergency environment for the suppression of neurocomplex tachydysrhythmias and for hypertension. It also has a use outside of emergency medicine for the treatment of angina. Calcium channel blockers are broadly classified as a von Willems class 4. It isn't really important to understand the exact mechanism of how a muscle contracts in order to understand how calcium channel blockers work. A simple understanding that if there's more calcium in the muscle, then the muscle will contract harder, and vice versa. If there's less calcium in the muscle, then the muscle will be more flaccid. So this is probably the most important thing to get. If you get nothing else, is the role of calcium in the muscle. If you have more curiosity about how muscles contract, it's beat to death in your A&P textbook. So the presence of calcium is required for the contraction of all types of muscle. So you have your three types of muscle. You have your skeletal, your cardiac, and your smooth muscle. Calcium channel blockers essentially work on your smooth muscle and your cardiac muscle. So as calcium presence goes up, so does the force of your contraction. The role of calcium channel blockers is to limit the release of calcium into the muscle cell. In therapeutic dosages, calcium channel blockers do not fully block the release of calcium into the cell, but limit the release according to how much of the drug is present. It's important to understand that calcium channel blockers do not block the muscles from contracting, but blunt the force of the contraction. So calcium channel blockers are primarily involved in just a few different components of the heart. So in the heart muscle itself, the myocardium, calcium channels are blocked, resulting in less calcium in the muscle. And less calcium in the muscle equals a weaker contraction. And it's also involved in the SA and AV nodes. Since the SA and AV nodes both use a slow action potential, calcium is used quite a bit there, and by blocking the calcium into these SA and AV nodes, essentially you're going to start getting a slower heart rate, and quite often that's what we're looking for. So that's a pretty important role for calcium channel blockers there. And also peripherally, it also plays a role in vasodilation, and this is the same principle as in the myocardium, where it's used to relax the smooth muscle by having less calcium inside the muscle tissue. Hopefully you should have a pretty good understanding of the role of calcium in a muscle contraction. So it's important we now understand how it is released into the muscle and what calcium channel blockers do to limit this release. The primary source of calcium into the cell for the purpose of causing a contraction is the sarcoplastic reticulum. However, unique to cardiac muscles is a calcium-rich interstitial fluid that bathes the muscle fibers. This interstitial fluid is released over a longer period of time, which is responsible for the longer contraction of the cardiac muscle. The difference is the primary reason why cardiac contraction is 10 to 15 times longer than a skeletal contraction. Calcium is released from these sites by calcium release channels. As you may have guessed, calcium channel blockers block calcium release channels, resulting in a reduced net outflow of calcium and preventing calcium from entering into the cell. It is important to understand the differences amongst calcium channel blockers. Although all calcium channel blockers have effects on vasodilation, the inotropic effects occur at varying degrees for each medication. Since verapamil, ditalizam, and adalat all belong to different families of calcium channel blockers, they all affect the cardiovascular system in varying degrees. Verapamil and ditalizam both cause vasodilation and SA-AV nodal suppression. However, they also may cause reflex tachycardia through stimulation of the sympathetic system. This is a pretty unfortunate event, since quite often they're being administered to treat tachycardias. Adalat, on the other hand, is pretty much used exclusively for its vasodilatory effect. It has very little effect on suppressing the SA and AV node, and unless it's quite outside its therapeutic range. Just to wrap things up, we need to discuss calcium channel blocker overdoses. Calcium channel blockers have a variety of treatment options, although none of these even come close to fully reversing the effect. Treatment options largely depend on the symptoms. Common symptoms for a calcium channel blocker overdose are hypotension, bradycardia, AV heart blocks, altered mentation, and dizziness. Transcutaneous pacing may be considered at any point in the treatment of bradycardia. However, due to the underlying cause of the bradycardia, the pacemaker may be unable to obtain mechanical capture. The first treatment option that should be considered is a fluid challenge of normal saline. An epinephrine infusion may be started with rates between 2 and 100 micrograms per minute. You may notice that this is 10 times the standard maximum dosing of epi. Treatment of the hypotension with a vasopressor is a priority in the treatment of a calcium channel blocker overdose. Secondly, an infusion of calcium chloride, 10%, with a dose of 8 to 16 milligrams per kilogram, given no faster than 100 milligrams per minute. If an effect is seen with calcium chloride, an infusion of 20 to 50 milligrams per kilogram per hour may be continued following the initial dose. Glucagon has been used with some success for the treatment of heart blocks and myocardial depression. Glucagon stimulates an increase in the heart rate through increasing intracellular concentrations of cyclic AMP. Atropine has mixed results. It can be used with some success in mild overdoses of calcium channel blockers. However, since the bradycardia is not vaguely induced, success is infrequent in severe overdoses. An important note is that patients should receive activated charcoal when they have ingested a slow-release preparation